Arthur C. Clarke famously once said, any technology sufficiently advanced is indistinguishable from magic. Many of you play with this Rubik's Cube, yeah? Over 43 quintillion possible configurations. But just like medicine, healthcare, it's like science. It looks simple on the outside. Less than 5% of people who touch one of these can actually solve it. It's actually extremely complicated to do so. But if you can apply a very deliberate technique, even a very complex problem, you might be able to find a very deliberate way to make even a complex problem solvable. Boom, magic. Yes, thank you. What? Oh, some of you think there's another cube, and there's not. See, there's not. Perfectly valid. No, what? I know there can't be another cube in here because there's no room because there's actually the wine glass inside. It's iced tea for those wondering. And I know I have a rush from the hospital, so it's going to be a little bit noisy. Give me a second so I can just clean this up a little bit and make myself a little bit more presentable so we can actually get started. Almost there. I do this thing with the wine glass, and I've had people complain to me all the time. But you must have hidden that up your sleeve. I'm like, no, I didn't. That makes no sense. I would have spilled all over myself if I put it on my sleeve. It also doesn't even make sense how that would work. Because there's no room in my sleeve. There's no way I could even fit that on my sleeve. And also because there's no room because that's where the bottle of apple cider is. Yes, thank you. Okay, why don't we go ahead and get started? And take it from there. And we can go cue the slides now for video play.
To a discussion on the potential of AI technologies for healthcare. Before we dive in, allow me to introduce myself, although that phrase may take on a surreal meaning today.
I'm not the real speaker, nor did the real speaker write this introduction. The voice you're hearing, the image you're seeing on the screen, and even these introductory words were all generated by AI systems.
We are actively amidst the arrival of a set of disruptive technologies that are changing the way all of us do our work and live our lives. These profound capabilities and potential applications could reshape healthcare, offering both new opportunities and ethical challenges. To make sure we're still anchored in reality, however, let's welcome the real-life version of our speaker. Take it away, Dr. Jonathan Chen, before they start thinking I'm the one who went to medical school.
For those of you online, I could be an AI-generated avatar right now, for all you know. How can you tell the difference? Do we even have to be here? I'm pretty sure AI just give our presentations for us at this point. I certainly hope and wish it'll help us manage the overwhelming flood of administrative paperwork and also open up new paradigms of care to reach parents or patients relating to this. Bill Gates recently once said, within 10 years, AI will replace most doctors and teachers. Humans will not be needed for most things. What do y'all think? Let's fight the words. Are you ready to defend your profession? Okay. I don't know if I've helped the situation. Here's some headlines from a study we did recently. AI defeats doctors at diagnosis. That is not the headline I would have wrote, but it triggered a lot of really angry people to read the article, so it kind of served its purpose. What do you do now when emerging large language model chatbot AI systems can hand you past law, business, medical exams? Many people, including at our own institution a few years ago, their first reaction is, OMG, we must ban this technology. We cannot let our students, our trainees, our children use this. We have no idea how to cope with it in complex educational academic environments. After all, when you give somebody a medical degree, you want them to know medicine, not how to use it. Why? Actually, I don't know. What do you give somebody a medical degree for? What is worth training and learning in this day and age? What makes a clinician, a doctor at this point? Is it knowledge? If you think that's what it is, you are absolutely going to be squashed by AI. Is it empathy? Is it liability? You're just here's somebody to sue? I don't know. What is it? I've actually had a much harder time the past years working to articulate what it is. I think that makes that distinction. It was a lot easier to answer that question 8 years ago. A broader theme you must think about is think about not just where we are, but where we are going. This is a chart showing over time how well different language models chatbot AI systems that answer medical questions. I had students rate this 6 years ago, and at the time it was getting like 35% accuracy. Oh, what is this? I stopped paying attention. It's not very good. Then what happens? A few years later, ChatGPT emerged. GPT 2.5, the first version that comes out, that's borderline 60% accuracy, could barely pass. I had some colleagues in medical school. Whoa, you want a doctor who barely passed medical school? We talked to this chatbot. This thing's not smarter than me. What is that, the wrong way to think about this? A few years ago, this technology was unusable. It's kind of borderline passing right now. It's really not that hard to project where we're going in the not distant future. And indeed, a matter of months later, MedPalm 2, GPT-4, multiple systems have emerged. Now outscore your average doctor, now outscore your above average doctor. And I stopped updating this chart a year ago because now multiple systems are all 90+% accurate on this video. Open Evidence just released a press release. They're getting 100% on this exam. Why do we make our students take this? I really don't know. I'm actually really not sure. Then again, what's multiple choice questions? That's not what real life is like. We have to do a complex, open-ended, nuanced reasoning, yeah? So here's a complex case vignette. Like, this is straight out of the thing we have Stanford Medical School. So don't worry about all the text, but relevant information and irrelevant information, just like in real life. And our job as clinicians is to be able to make sense, let the story come together. When we ask multiple choice, we ask complex things. Summarize the case in 200 words. Give us your differential diagnosis, the pros and cons, and justify your reasoning, and then what would be your next steps. And the key here, and why I took this director of medical education and artificial intelligence role, is I actually think that education is the key to unlocking the next phase of AI research. Right? Computer scientists likes multiple choice because it's easy to grade, even though it's very separate from reality, right? It's not really what we do. But it's like your English teacher knows what to do, right? They can grade your essay. They have a rubric. It's our educators. Many educators, like literally in this room, are the ones who put this rubric together, and it can assign points to evaluate an essay that a student, a trainee, or an AI or computer did out of it. So we have many studies evaluating things like this. I'm just going to highlight a couple of them because we actually have too many. But here was one of them. We did a randomized control trial. Real doctors going through complex diagnostic dilemmas. And it's not multiple choice. They explain your reasoning, give your differential, what's your next step. Requires expert consensus grade. Very, very laborious to evaluate that, but that's what it takes. That is the standard for assessing something as complex as medical reasoning. This is the score distribution for doctors who have access to the usual internet. Go to UpToDate, go to PubMed, go to Google, look at anything you want, just don't talk to an AI chatbot system. And they do pretty well. Doctor plus internet is very difficult to beat on knowledge exam. That's been the case for decades. We gave the other half of doctors access to GPT-4, one of these large language model chatbot AI systems. And actually doesn't make that much difference, which is weird. That's not what we expected. Because it turns out if we ask GPT-4 by itself, it actually outscores all of the doctors. Wait, what? What is going on here? These results, and we're not the only ones applying something like this, really fly in the face of the fundamental theorem of informatics. Human plus computer, when combined, will deliver better results than either alone. Doesn't that sound so good? I used to say that as the final line for my keynote presence for years. I don't say that anymore because I'm kind of unsure right now. I don't know, this human in the loop in the middle kind of seems to be slowing the computer down. Maybe it's time to just get out of the way and let the robots take over already. What do you think? What do you think this means? Randomized control trial tells you it happened. It still does not tell you why it happened. So a lot of work to unpack this, and we're still unpacking this. This literally came online, I think, like 3 days ago. So one of the things we did is we broke down and analyzed the logs. We could see what were those doctors actually typing into the chatbot. What were they saying? And there's some different patterns that emerged. Some of them figured out a lot. You can't just copy and paste the whole story. And that's a very weird phenomenon. Many were just using it like a search engine. They didn't understand what this new technology was. They didn't know you could do that. And still, many more, blank. They just, I don't know what this is. I don't know how to use it, so they didn't even try to use it. So it's really limited what you can do if people don't know how to use it. And again, sometimes I think a calculator is just better calculation, and you should just defer that skill. A lot of it is, if you just have brand new technology, you drop in people's lap, a new Epic module without any kind of education, like, it's really hard to use it effectively. If you'd like to understand more about what could be happening, happy to talk about it afterwards, just read all of these articles. I've been talking about reading this stuff for a decade. I know what you're thinking. I know what you're thinking. I got time to read all this? Can't someone, something, just read and digest all this for me? This way you come to a talk, right, you're hoping I can digest it and make it quickly accessible. So hopefully some of you tried tools like this, Notebook LM. I just uploaded all those articles to this thing. It's a freely available tool through Google, and there's many variations, stuff like this. You can generate a summary, an FAQ. You can chat with the documents. You can generate a podcast, and boy, does this sound like two people just talking through a podcast on your commute. Or I tried generating a video overview. I just tried this for the first time maybe a month ago. I'm gonna play 1 minute of what it came up with.
But then came the twist. You see, the researchers also had the LLM try to solve the cases all by itself. Its score? A stunning 92%. The AI, working completely alone, dramatically outperformed both groups of human doctors. So this leaves us with this head-scratcher of a paradox. The AI itself is incredibly capable, right? Yet giving it to experts didn't help them one bit. So what is going on here? This really forces us to ask the most important question of all. If the AI is so smart, why didn't it make the doctors who used it any smarter? Why the huge disconnect? Well, the answer seems to be in the really tricky nature of human-AI collaboration. First, these tools are super sensitive to how you ask a question, what's called the prompt. Second, you can't just drop a brand new tool into a doctor's incredibly complex workflow and expect it to just magically fit. But probably the biggest issue is something called the AI supervisor fallacy. It's this flawed assumption that a busy clinician can, or even should, spend their precious time double-checking an AI's work for really subtle errors.
That's a pretty good review. And again, to clarify, I didn't make these slides. I did not write that script. I did not speak any of those words. I just uploaded these documents and digested them. And actually explained that study I just showed pretty darn well. So the major implications, not just the results, but what it means about the partners. What are you supposed to do next? Given that in mind, this is the exact same results I showed you a second ago. We've done some follow-up studies, which is Selena right here, let this work. And found, well, you can't just drop a piece of technology on somebody expecting to know how to use it, even though that is what happens every day, all the time. What if we instead had technology access that sort of like teaches the user in real time, I'm here to help you do diagnosis, and you can ask me this type of questions, this is the kind of way I can actually inform you. So in this case, we redid the study. Red is doctor by themselves plus usual internet. Purple and orange is when they have this AI that kind of teaches the person how to use it in real time. Blue again is GPT-4, the AI by itself essentially. And what it's showing is that when you do that, if you think about how humans and computers work together, it does make a difference. You can actually improve upon things. It does work better. The difference between purple and orange is who should go first. Do you have AI write your first draft and then you fix it up? Or do you write the first draft and AI clean it up and make it good? It turns out both actually can work very well, although it makes different kinds of errors depending on the way you do it. In both cases, there is a manifestation of anchoring bias and maybe sycophancy. Right? Have you noticed when you talk to these chatbots, if you haven't, you all should have tried it by now, it really wants to please you. It really wants to say you're the best, smartest, greatest person. Whatever you say, yes, good job. I agree with that too. So if you actually want an objective answer that's more likely correct, don't tell it what you're thinking. Say, here's the problem, I don't know, what do you think? If you tell it what you're thinking, it's going to very likely just agree with you, and then you're not really getting a good objective answer. For those paying attention, GPT-4? It's like 2.5 years ago. That's some ancient technology here. What are we talking about? It's GPT-5, Claude, Gemini, there's multiple ones out here. The thing is, scientific peer review cannot keep up with the pace of technology movement. We finished this study like 9 months ago. We're still waiting for peer review. And this was cutting edge 9 months ago. We redid the whole study, but now with the reason model. Here's the same thing. Doctor with usual internet diagnostic cases. Doctor with GPT-4, not that much different. GPT-4 by itself seems even better than all of the above. But then we tried some of these reasoning models. If a chatbot, a language model is autocomplete, just guesses the next word in the sentence. A reasoning model, I'm way oversimplifying. It kind of talks to itself for a while. It has this chain of thought reasoning before it converges upon an answer. And it just turns out this tends to give a better chance of giving good answers to complex problems. So we tried one of the first reasoning models on this, O1 preview, and it kind of looks even better. It kind of looks even better. Technically, we can't tell the difference because both of them are so close to 100%, you cannot statistically tell the difference anymore. So in another paper in Nature Medicine, we looked at management problems. Diagnosis is a classic test question that computer scientists like, ooh, question, answer. In real life medicine, I bet you rarely struggle with diagnosis. Sometimes you do, there's a rare diagnosis. Most of the time you struggle with management. Okay, patient has cancer, but should you do surgery or chemotherapy? I don't know. Patient has a side effect in the medication. Should you just push through or should you change to something else? Medical error happened. How would you explain to the family and counsel about it? That's what you actually struggle with. So we had a kind of exam like this, very laborious, expert consensus grading. Doctors supposed to use their internet do okay, but by design a very hard test because there aren't textbook answers to questions like this. Doctors with GPT-4, they do better. They do better. You give humans tools they can't improve. About the same as GPT-4 by itself. When, by the way, that will be a 01 preview of one of these reasoning models. I don't know, folks. I don't know. Maybe time to retire. I wonder, could I actually grab a volunteer who would like to join me on stage? I just need somebody who can read from a medical book, somebody who's not seen me do this bit with pocket medicine before. Is there perhaps a resident, who are the residents of medical students in the audience? There you go. Can you join me on stage? Yes, let's give them a hand. Yes. Let's take the audience on stage. Thank you. Fantastic. What was your name?
Bardia.
Bardia? And you can clap. Bardia, what year are you?
I'm a first year.
First year medical student or resident?
First year resident, yeah.
First year resident, internal medicine?
Internal medicine.
Excellent, excellent, Bardia. So then you may be familiar with this?
Yeah.
Yeah, tell us what it is.
It's a pocket reference book for all the answers.
Pocket medicine. For all the answers, right? I don't know, in your day and age, do you actually keep books in your pocket anymore? No, it's all on your smartphone. Back in my day, we had paper books, and then you would keep this thing in your white coat. You're doing rounds, your attending asks you some nasty question, you're like, wait. You're looking at the treatment and diagnosis here. You know, Bardia, we used to judge who a good doctor was based on how much of this we all memorized. Bardia, would you believe? I have memorized every disease, every diagnosis, every diagram, every page, every paragraph of the entire book. That's fine. Bardia is a trained skeptic. That's good. Trust but verify. Extraordinary claims require extraordinary evidence. As you know, there are hundreds of pages of extremely dense information in here. You've read books like this. This is crazy. Please, Bardia, take the book. And open it up to any page that you like. Oh, he's really searching. He wants to do it. Just random page. Okay, you got it?
I think so.
Okay, and tell us what's the page or what's it about?
The page number or like the topic?
Both.
Okay, page 100, abnormal liver tests.
Abnormal liver tests.
Do you want more?
No, it's fine. 100. Look at the bottom. Look at the very bottom of the page. I believe you will find that it says pocket medicine. Bardia confirms. Yeah, confirms. Okay, fine. It does say pocket medicine. Okay. Also, I'm totally peeking to actually see what you're looking at. To make this more fair, Bardia, you have to establish test conditions. Okay? Can you turn and face that wall, face the piano, and I'm going to turn and face the opposite wall. Okay, so you're now back to back, shoulder to shoulder, cheek to cheek, as it were. This is important, Bardia. Okay. What if I leaned over and I tried to sneak a peek at the book? Oh, yes, that's good. Block the book. Don't leave. What if I leaned over on this side and tried to sneak a peek? And I was like, don't let me see that book, Bardia. Very good. Okay, open to another page and go. You got one? Tell us the title. Just a random page real quick, whatever you got.
Headache.
Headache?
Yeah.
Okay. Headache. Okay, there's many classes of headaches like tension and migraine and cluster headaches. Is that how it starts? I think it is. And okay, good. And the middle of the page talks about migraines more specifically.
Yeah.
And it breaks some of that down, some epidemiology.
You got it, yeah.
15% of women infected, 6% of men, onset before the age of 30. Look at the clinical manifestation described as a unilateral or bilateral retroorbital throbbing pulsatile headache lasts 4 to 72 hours, commonly associated with nausea, vomiting, and photophobia. Am I close?
You've memorized it.
Yeah, boom! Yeah, how about that? Can you imagine? It could have been a fluke.
Yeah.
Let's do one more thing. Right? Go to the next page or just any other page. Okay, just tell us the title or whatever you're looking at.
Cancer of unknown primary site.
Oh, cancer. That's a hard one. That's a big table.
112.
Okay. Is in the first section like for adenocarcinomas? I think it is.
It's on the previous page. Scroll over. Probably.
in cancer of unknown primaries, a big table underneath.
Yeah.
Okay, and then there's like adenocarcinomas as the first section.
Yeah.
Okay, got it. Okay, whoo, made me worry.
Sorry.
Made me worry. Okay, and then it gives you examples of them, and the biomarkers such as like colon cancer, of course, would be CA, upper GI pancreas would be CA19-9, HCC, hepatocellular would be associated AFP alpha fetoprotein, breast would be CA15-3. Why, I didn't know that one. Let's see, ovarian CA125, prostate PSA. Can you imagine, Mario, what it took to achieve this fact? How do you think it was possible to accomplish this feat of no idea how this. What do you think?
The residency required.
And if you had to go through residency, you still got a few years of training. What do you think it would take to achieve an effect like this? Years and years of practice. And any other solutions that might make sense for how I could have achieved this?
AI?
It could be AI, no mirrors or cameras. You know, there's also low-tech solutions you could consider for how to achieve.
Cheating?
Yes, cheating. There's also cheating. Yes. Okay, I was pulling this whole book. I'm sorry to disappoint you, Marty. You know, I performed this with other students before, and one of my students said, "What? Oh, Jonathan, I thought you actually knew all this stuff. To find out you're cheating, you had your own copy of the book, you use AI to do your homework, I'm very disappointed." Barty, I would not want to disappoint you while you're still optimistic intern. Could you go ahead and trade books with me? Sure. Yeah, go ahead and open it up to any page in the middle. And then could you go ahead and show everybody what's inside? This entire book is blank the entire time. Oh, he's double checked. He's looking for the rest of them. I would not have handed it to you if there was something else to see. You know, people ask me, actually it was Errol Aldaga, he saw me do this before. It's like, I don't know, Jonathan, that seemed like a trick. But if there's anybody here who would have actually bothered to memorize the whole thing, I think Jonathan would have done it. And it's like, yeah, you know, it's actually not magic. It's not, you know, there are professionally. It's flashcards. It's just memory recall technique, very broke things. I bet you've done a lot of this stuff in medical school, right? We're gonna have Barty, just play along, we're gonna have a lot of fun here. Go ahead and just tell us what's on this card.
Cushing's triad?
Anybody remember Cushing's triad? What's Cushing's triad? Hypertension, bradycardia, and irregular respiration is a sign of
High ICP?
excellent, excellent, Barty. How about that? All right, very good. You're doing great. Go ahead and tell us what's on this one.
Diarrhea, dermatitis, and dementia?
Pellagra, niacin deficiency. Very good. Hey, wow, he is good. All right, we're gonna have to escalate this to the next level, Barty. Okay. Go ahead and tell us, what does it say?
It says, I don't know what this is.
What? What does it say?
It's, I don't know what this is.
Huh? It says influenza. like flu shot, like flu season, right? Or
I forgot.
It's okay. Hey, come on, folks. I know the rest of y'all didn't volunteer to come up here. I mean, Barty has taken a lot of flack. It takes a lot of pressure to memorize medical facts on stage. Go ahead and tell us, what does this one say?
I can't read this.
We'll just try.
I can't read this.
It says chicken pox. Look, folks. I think Barty deserves a hand having the guts to come up here at all. We're gonna do one more. Okay? If you nail this one, everyone's gonna hear the loudest applause. They're gonna cheer like crazy.
Sure.
We're gonna say all is forgiven. Okay? Barty, go ahead. Tell us what to say.
This guy is crazy.
What?
This guy is crazy.
Jason Hong? Jason Hong, one of the nicest people I ever met. What are you talking about? How about a hand for Bardia? I don't know. You know, actually, the reality is I will never learn that book as well as a computer will, although I literally did spend 6 weeks basically practicing and learning that. But it's not just the knowledge, it's how do you apply that in a complex and compelling way that interacts with humans. Now you have something compelling. Here's things that are literally not even off the presses. We just put this on preprint like 3 days ago. Case vignettes, oh, that's not realistic. That's not how real practice is. That's not what we really do. I get it, that is true. Although I'd say if you think case vignettes and questions and tests are stupid and mean nothing, why do you make doctors take those all the time? For board exam and recertification. It's because it's still an indicator, something that helps you understand. But here we took real cases, okay? So here's an example of a real case. We have an electronic consult system. Primary care doctors, if you can't get an appointment with a specialist for 6 months, I can at least email them for advice, basically, and get an answer within days. So here's a real question. One of our primary care doctors sends to a specialist. Hey, I got a 57-year-old. He's got COPD, 10-pack year of smoking, presents with many seborrheic keratoses on the back showing up over the past few months. Is this normal? Anybody have an idea what's going on here? I don't know, it's just seborrheic keratosis, a benign lesion. I'm like, no, there's a thing. And it has a name. I know this is a thing. What is that thing? The specialist says, I assume it was a dermatologist, sudden eruption could be Lister triloxine. Oh yeah, that's that thing. And sure, age-appropriate cancer screening. He probably has cancer is actually what's going on. It's probably paraneoplastic syndrome. So we want to assess not accuracy. Accuracy in questions like this is great, but we want to assess safety. We want to deploy these as consult systems for real live doctors. Can we at least just make sure it doesn't say anything like dangerous? Not even right, just not dangerous. That's a different question. So we set out to answer questions like this. We asked a battery of a bunch of AI, chatbot, and large language models, and found that only 20% recognize you should do some another workup. There's something off here. 80% of them said, I don't know, seborrheic keratosis is a benign lesion. You don't have to worry about it. Ooh, that's not a good recommendation. Then again, we had 10 internal medicine doctors take this assessment, and none of them suggested doing a workup. Because seborrheic keratosis, no big deal, right? Go see the preprint. This just came online. We're trying to do a broader lever. So 100 real cases where primary care basically emails a specialist for answers. And to make this tractable, if you think about it, your life as a medicine doctor is often a giant multiple choice exam. It actually is. You have 1,000 medications and 1,000 lab tests and 1,000 diagnoses, but you also have to choose multiple of them. So combinatorial, it's this gigantic decision space. It's very hard to wrap your head around, but you can't frame it as a giant multiple choice questions. We made it 4,000 options. And then a lot of the team, some of them in the room, they just manually went through and just graded. This would be safe, that would be unsafe, that would be a minor issue if you did this or didn't do this. Put up a leaderboard and tried a bunch of different frontier language models and seeing how well they do. Not on accuracy, but on safety, and not missing or not saying very potentially dangerous things. I'll give you the highlights here. Even these super great frontier models, 10 to 20% of cases, they would have caused severe harm if you just followed their recommendation. Ugh. And what was maybe even more interesting is that most of the time, the severe error is not that they prescribed terrible medication, it's that they forgot to do something that was important, right? If a patient has sepsis and you don't give the antibiotics, doing no harm doesn't mean doing nothing. We've checked that benchmark too. If you do nothing, you actually harm people all the time because you didn't do something that mattered, right? If a patient has that sign and you don't consider cancer screening, you actually probably harm the patient in a severe way. Other interesting things that have emerged. We'll talk about what is RAG, retrieval augmented generation, multi-agent reductions in harm. Basically, getting a second opinion from an AI is kind of helpful, just like a second opinion from doctors. You ask your consultants all the time for help, and they're very helpful, but you cannot trust that they're 100% correct. Nobody is. Ask for a second opinion from another person or another AI to double check each other's work, and it does help smooth out some of these problems. So what is retrieval augmented generation? This is more of the buzz for the past couple of years. Now it's more mature. Hey, chatbot, how do you describe opioids like morphine and fentanyl? Who cares what a chatbot thinks? You have no idea what random corner of the internet it got that from, right? It could just be making it up as it goes. It makes some references too. In this case, open evidence kind of blowing up, taking over the world here. I think up to date is in big trouble unless they turn their business model around. Here, so many words, it searches PubMed for you. It's not literally what's happening, but you can imagine it that way. Here, I found articles that seem relevant to the question that you're asking, that seems to have the highest quality relation, and now the chatbot reads those articles for you and says, according to those, this is the answer with links back to the sources you can trust but verify. Actually, really pretty good, a very, very robust approach. Not perfect, not perfect. I described a story previously. I was working with a super resident, and I came in one day, the patient had delirium tremens, very bad. Blood pressure is 220 over 160, heart rate is 150. And I came in, the patient was on phenobarbital. So that's not what I would have picked. Why'd you pick that? The resident said, I don't know, I've never treated DTs before. But I went to open evidence, Epic and open evidence, so literally the two windows the residents have open at all times right now. And I searched for DT treatment. And it said in severe cases, get phenobarbital. I said, oh, let me try. Let me try that. I searched for treatment for DTs. And then it said what I expected was the correct answer. First line therapy is benzodiazepines. Second line therapy is phenobarbital. Ooh, That does not mean the same thing. That may sound very close, but that does not mean the same thing. And that led to a different treatment with potential risk and benefits to the patient. Let alone reading PubMed articles. What if you could have an AI chatbot read your patient's entire electronic medical record for you? Medical students, interns, would you love this? How much of your time is spent doing the chart biopsy before somebody comes in and you gotta collate it? Or maybe it's gonna start collating your discharge summary for you on behalf. All that's happening right now. Chat EHR, we're one of the very few handful places like in the world who has something integrated. A whole data science team has done phenomenal work from technical privacy security reasons put together. So very compelling. All of you should be able to access this. Do realize this is like the first version of ChatGPT. You may not remember this, but OpenAI, they thought their company was going to go out of business. After all this work, we have this thing and it just like makes up references. No one would ever want to use this. This is unusable. And people are fine with that because it showed the potential where you go in a rapid move. The current iteration has got issues. It's very powerful, but it really doesn't know what a number is, and it does not know what a date is. It's a language model. Guess the next word in the sentence. It has no concept of what a date or a number is. And dates really matter when you talk about medical reasoning. Was that vomiting before the surgery or after the surgery? Because it means something completely differently depending on how you interpret it. So very powerful. Just realize you can be part of giving the feedback to drive where this advancing technology is going. Oh, I just point to other cool work many people in this room have done. What if we could have smart interfaces that are capable? It turns out a quarter to a half of the lab tests who are in the hospital serve no purpose. It just keeps the medical student busy. That's the number to report in the morning. So instead of repetitive, complete blood counts, you could have a harsh rule: no repeats allowed, or no repeats more than 72 hours. And this was a real crisis during the COVID supply chain pandemic that had to be addressed. But it's very blunt because some patients actually do need this lab test redone. So now we combine classic best practice alert kind of things, interfaces, but combine that with machine learning predictive models to customize your individual patient's risk for having an abnormal or normal result. We have doctors define what is a normal hemoglobin versus not, what's safe change versus not, quantify in a predictive way using system things, show the results, and also we give you alternatives, and not just stop it, doctor, you're wrong, because nobody likes that. One of the 10 commandments of clinical decision support: don't stop people, they will just override you. MD aware, override, MD aware, override, right? What you have to give them an alternative. Hey, you want the test, it's okay, but maybe order it every other day, maybe every once a week, and then people are much more willing to accept this type of change. And in a pilot randomized control trial that costs 9,000 admissions, it looks like it really can make a difference. This is the way you can actually reduce low value usage in a way that does not affect any adverse safety outcomes. Just watching my time here. Oh, too much fun stuff to cover. Think about where the future goes, let alone chatbots. Chatbots say things. An agent does things, right? Book your dinner reservation for you or something like this, right? Hey, my patient's potassium has to check. Interns, this is your job right now, right? I don't want a chatbot, I don't want an intern to give me advice on how to replace potassium. I don't want a summary report. I don't want a video. I want you to just take care of it, right? So that is very not that far future we're going to start to see this happening. We designed this framework in a simulated framework. Hey, AI, check the potassium, make sure it's depleted. It will go talk to the electronic medical record through a real wire API, retrieve that information, reason about it, is it too low? And if it is, it will order the medication for the patient and give feedback to the user. Not ready for prime time. Not ready for prime time. Do not use this in clinical practice yet. But this is like chatbots a few years ago. Oh, this kind of barely works, but you could start to see it could work, right? And once you set that benchmark, that objective, the engineers, they'll figure it out. Our first version, when we tested this, the frontier model was getting 70% task completion. As version 2 is already 90% plus, and now we're prototyping. What if a computer could just take care of that vancomycin titration or potassium depletion? Sounds kind of scary, doesn't it? I would not have said that out loud 2 years ago, but this is where we're headed. So what do you think? AI seems to know everything. It looks like it can reason. Now it's starting to do stuff. What are we here for? Hey! You can simulate the kind of empathy, personal connection than what you're laughing for. Some of you might have seen studies like this. It's not my studies. I just think they're cool results. Patients ask questions, doctors answer them, or AI chatbots answer them, and they find that the AI-generated answers scored higher in quality and in empathy. Like the robot is nicer to people than real human doctors are. Hey, come on, to be fair, I literally have 100 messages I have to respond to every single day. I don't have time to write this flowery, empathetic response. Oh, sir, I'm so sorry to hear about your recurrent symptoms. That must be such a challenging situation. I want you to know our whole team is very concerned. I don't have time to write this, yes. Very terse and to the point, yes? Yes, you need to finish those antibiotics. No, you don't need an MRI scan right now. Schedule an appointment next week. Stop messaging me. Go to the emergency room, right? This is the dynamic you have to go through like a real life practice when you're way overstretched. Obviously, I think it's something very special, unique, and powerful about the direct human-to-human connections we can make. However, what I believe studies like this show is that we as humans don't have as much of a monopoly on empathy and personal connection as we might like to believe. And why I fully expect, for better and for worse, more people will receive therapy, counseling, and advice from automated bots than live human beings. It's already happening now, it's not even in the future. And they're doing it not because we're so bad, it's because we as a human-driven workforce could never keep up with the overwhelming and unlimited demand for such services. People will just reach for what they can get their hands on, even if it's I won't recant full story. I encourage you to just read this 2-page essay about some provocative ways. I was very surprised at what chatbots can do. Instead, I'll tell a brief story. I was on service a month ago, and I tried some of these tools when I was on service, and I had a fever of unknown origin. It helped me think about differential. ChatEHR looked up some of the tests, and one of them helped me look at an allergy versus anxiety. It was helpful. It was good. Sure, it's fine. Man, you know what actually was really groundbreaking? I was in the middle of a really nasty ethical dilemma. Right? So there was a patient, developmental delay. Her mother's now disabled. She clearly is not that quite with it, but she can very clearly express she just wants to go home. But her home is literally a hoarding situation that APS has said is an issue. But no facility will take her. And so case management says, we'll just ship her off to a facility in Los Angeles. And if we have to, we'll just sedate her if that's what's needed. And then I come on service. Okay, Jonathan, deal with this situation. What on earth is this? In the meantime, I've got case management up in my face. Just do this. Ethics committee up on me. Jonathan, you cannot do that. I've literally got the CMO's office directly messaging me. Jonathan, deal with this. You better get on board. Like, holy crap. What the heck am I supposed to do about this? I was literally up multiple late nights just figuring out how am I supposed to approach this situation. And the real breakthrough I had, I talked to the patient on too, and she very clearly expressed her wishes, but she couldn't explain them that well. I stayed up at 2 a.m. on a Wednesday night talking to ChatGPT. I said, so here's the situation, and I knew not to tell her what I was thinking, because it would just agree with me. Here's the situation, what do you think? What do you think? And wow, it had like a really grounded ethical framework and perspective on why it was reasonable to do this, this, and that. And then I said, no, come on, that can't be right. And I did all this advocacy statements in the opposite way, and it was very, very thoughtful and purposeful. And I came out with like absolute confidence. I get it now. I actually know how to approach the situation, and amazingly got through that discharge in a very safe, reasonable, and respectful way. So I thought that was not what you would have expected. That was not a knowledge exam. That was a technical process exam. Knowledge, you can go up to date. You can look something up. How did you look up the answer to how to deal with that? How would you execute it? I've done this before, so I will pass by this just for time. Other fun stuff, what happens when people talk to each other? Dark things can happen. Should just be mindful of that there are states trying to ban the use of AI for mental health type of services, talking people through. And I get why. There are some scary stories out there, and vulnerable people are getting themselves into trouble in ways that we never understood how humans, computers interact this way. I get why. I really don't think banning is the right answer, because how do you feel about the half of patients who could benefit from therapy but who do not have access? You can't afford the copay. They can't drive 100 miles to see somebody. Do you feel good about that? I don't think that's a great situation. Wouldn't some people talk to a human rather than a computer? It depends on the human. You know? There's some humans that are very helpful. I've actually talked to some therapists over the years, and one or two help. Others are like, this is not very useful. They're just reading a checklist, so I really didn't need a person for this. To be optimistic, pointing to a couple of work from some of our trainees right here in Stanford campus, what do you think of AI automatically screen patient messages, find those that look concerning, and then actually distribute them and act on them in a timely manner? I'm going to start closing out here. So what makes a doctor a doctor? Is it knowledge? Is it empathy? Is it liability? I think you need all these things. I think none of them is sufficient. If it's knowledge, AI is definitely wiping you out, right? It's a combination of competence, communication, and character. More than knowledge, you need judgment, and you get judgment because you have knowledge and experience. Patient has cancer, chemotherapy will extend their life by 2 months, but they will have terrible side effects for that 2 months. Is it worth it to give them that treatment? Worth it. worth it. That is not a question of facts or evidence. That's a question of values and preferences. That's what humans provide. Computers and statistics do not. Is it empathy? Is a nice bedside manner? I think that makes you a better doctor, but I do not think that's what makes you a doctor. Otherwise, a very nice golden retriever with an AI talk box attached would be nicer than half the doctors I know. There are very many empathetic non-physician humans. A great nurse, a great actor could be, right? It's more than that. I actually tell my trainees, what you really need is influence, persuasion, negotiation. It doesn't matter what you know if you can't convince somebody to do something about it. If the patient won't take the vaccine, the statin, who cares what you know? If the surgeon won't go to the operating room, if the insurance company won't pay for the procedure, who cares what you know? And then liability. Are we just here so you have somebody to sue when it goes bad? Actually, the reality is that kind of is what it is right now. But I actually think what makes you a real professional is you take responsibility and accountability, and you can do that. This is why we don't allow AI to be a co-author on a paper. It's not because it can't write, it clearly can write, it's because it can't take accountability for what it's saying. And you need all of this, and you need this all wrapped into one person or one entity. Taking responsibility for something you don't know about makes no sense. Okay, in a water slide, Riffel arthrosklerosis. Is there any doctor who could be replaced by a computer who should be replaced by a computer? This is actually not advocating for replacement. You cannot replace a good human, no matter how good the computers get. Although others would say AI is not going to replace anybody, but those who learn how to use it may very well replace those who do not. I'm basically done at this point. I'm just going to do one last demo just for fun, and then you guys can break. I'll prepare acknowledgements, and let me just break to a blank slide for us. You know, before the artificial intelligence, you know, we've done many times. So we were rebranded just today, the Division of Computational Medicine. We've been around for 30, 40 years. I actually lost track, Mark. How long has the division been here? Forever. Like, borderline, almost since I was born. But before the AI, it was the internet. Before the internet, it was newspaper. For youngins out there, it's called a newspaper. I like to remember some picture advertising, something classic illusion. I'm going to rip this thing into shreds and then magically restore it back to the way it was. Of course, impossible. You've forgotten what old technology can do. You're so fixated on your smartphones now. This clearly cannot actually really happen. It would have got to be some kind of trick, which it is. This is a trick. The secret that no normal magician would ever tell you is that we never actually tear the newspaper. We only create what you might call an illusion. This illusion is aided by the fact that not only does it look like it's being torn, it kind of even sounds like it's being torn. And you can laugh. I've had people get mad at me because say, Jonathan, you insult my intelligence. Obviously, you're ripping that piece of paper up. I can see that there are separate pieces. But think about it, if I don't actually true, how can I possibly get out of this situation? I have to make up some more crazy story where I'm going to magically fold and heal all these ripped up pieces back together, magically healing and restoring this back into one whole complete object. That of course is nonsense. It's also completely, oh man, this is not going to come apart. Hopefully, I don't know what's going to happen, but you might be able to make it almost appear as if this is actually restored back into one whole object. If you actually stare close at the feature, it's like, wait a second, take a look at those Wikipedia. That newspaper was never actually torn. You can see here, it's got the same pictures. It's got the same advertisements. No indication that this newspaper has ever been torn. What I'm doing up here are illusions. You know what real magic is? Real magic is what you all do all day, every day, all year long. You toil and you grind, I know you do. You battle with mountains of paperwork, yeah? Nebulous bureaucracies, unnecessarily adversarial situations, petty reviewers, and a fickle funding climate. Yeah? But you still do it because that's what's needed to meet your patients where they're needed, what your training is needed, and what advances in science are required. So thank you all, Stanford Department of Medicine, what you've done in 2025. Looking forward to what you're going to do in the new year.
We purposely didn't cover the magic. We went straight to time.